points about your warfarin is that warfarin, remember, it is a racemic mixture, right? It is the racemic mixture of R and S isomers. Right, racemic mixture of R and as well as the S isomers. Now, out of this R and S isomers, the S warfarin is more active. Right, this S warfarin, it is more active, and this particular S warfarin, it is metabolized by an enzyme that is CYP2C9. It is more active. It is metabolized by an enzyme which is called as CYP2C9. Now, if there is any polymorphism of this CYP2C9, polymorphisms in CYP2C9 may affect the activity of warfarin among different persons. That means if there is a single form of CYP2C9, there is no problem, the S warfarin, it gets metabolized. But if there is any mutations or any formulations of CYP2C9, then that may affect the activity of warfarin among different persons. Okay, so remember, right, polymorphisms of this particular CYP2C9, this may affect the activity of warfarin. Right, this may affect the activity of warfarin among the different persons. Now these are some of the points about your warfarin. Continuation with the same oral anticoagulants. Remember, what was your oral anticoagulants doing? The oral anticoagulants, they are inhibiting the vitamin K dependent factors, that is 2, 7, 9, 10, and not only that, they are also inhibiting the activity of the anti-clotting proteins, that is protein C and as well as protein S. Now, among all these 2, 7, 9, 10 and as well as the protein C and as well as protein S, you take the clotting factor 7. Right, you take the clotting factor 7. This particular clotting factor 7, it has the half-life of 6 hours. Right, it has the half-life of 6 hours. Now, because it has the half-life of 6 hours, among all the clotting factors, this is the one which is first to disappear. Right, this is the one which is first to disappear. Right, and you take the clotting factor which is last to disappear among your 2, 7, 9, 10. Remember, the last to disappear is factor 2, which is having the half-life of 60 hours. Okay, so the last to disappear is factor 2. Right, and this particular factor 2, it is having the half-life of, right, it is having the half-life of 60 hours. Now after having discussed about the clotting factors, you take the proteins, that is protein C and as well as protein S. The protein C, it has a shorter half-life, that is nearly around 8 hours. Right, protein C has half-life of the 8 hours. So remember, among your protein C and protein S, the first to decline is your protein C. Right, so this is first to decline, and Remember, whenever there is deficiency of protein C, this may lead to dermal vascular necrosis and hypercoagulation, right? If there is deficiency of protein C is what? It's an anti-clotting protein, it's a natural anticoagulant. So whenever there is deficiency of this protein C, right, deficiency of this particular protein C will lead to dermal vascular necrosis, right? It will cause what is called dermal vascular necrosis, and as well as it will cause the hypercoagulation. Alright. Now, this particular dermal vascular necrosis and hypercoagulation, they occur as early appearing adverse effects of warfarin and other group of these particular drugs. So what does your warfarin do? Warfarin will inhibit the factor 2,7,9,10, and warfarin will also inhibit the protein C. So whenever there is deficiency of protein C which is caused by the warfarin, immediately the individual can have this dermal vascular necrosis and as well as the hypercoagulability. Alright. Now the other important point is, you take this oral anticoagulant. The effect of oral anticoagulants is always delayed. I have said you. Why? Because the oral anticoagulants, they will prevent the formation of the new coagulation factors, but they don't have any effect on already formed factors. Therefore, the effect of oral anticoagulants is always delayed. They develop gradually over 1 to 3 days or 2 to 3 days, and thus these particular drugs are used for maintenance of anticoagulation rather than initiation of the treatment. Okay. Now one point what you should remember here is, this particular oral anticoagulation, the onset of action, it is delayed, right? How much it is delayed? Of nearly around 1 to 3 days, right? The onset of action is delayed gradually over 1 to 3 days, and that is the reason why these are used only for maintenance treatment. Right, these are only used for the maintenance treatment rather than initiation. Okay, so the point is, these drugs not useful for initiation. So these drugs, they are not useful for initiation of therapy. Alright, so this is about your warfarin, but remember, what is the adverse effect associated with the warfarin? Bleeding is the most common adverse effect. Now I'll tell you the adverse effects and how do you treat that particular adverse effects. Let me discuss. So before going on to the discussion, one important point what you need to remember is, these oral anticoagulants, that is warfarin, it is in the form of the racemic mixture, and that is the R and as well as S isomer. Among that, S-warfarin is more active and it is metabolized by CYP2C9. And polymorphisms in CYP2C9 may affect the activity of warfarin among different persons. And among the coagulation factors, remember, first to disappear is the factor 7, right? Because the half-life is 6 hours. And last to disappear is second factor, that is why? Because the half-life is nearly around 60 hours. And you take the anti-clotting proteins, that is protein C has the shorter half-life than most clotting factors, that is around 8 hours. So it is the first factor to decline, and its deficiency may lead to dermal vascular necrosis and hypercoagulation, which will appear early after the starting of the warfarin group, right? And another point is, the effect of these particular oral anticoagulants is always delayed, gradually over 1 to 3 days, and that is the reason why they are used only for maintenance, not for the initiation of treatment. So now let me tell you the adverse effects and how do you treat that particular adverse effects of your warfarin. So if you take the adverse effects of the warfarin, remember whenever there is the warfarin overdose, the most common adverse effects of these anticoagulants is bleeding. Right, the most common adverse effects of this anticoagulants is the bleeding. Now if the patient develops the bleeding, right, if the patient develops bleeding due to overdose of warfarin, the treatment what can be given is fresh frozen plasma, right. Fresh frozen plasma is actually the treatment of choice, but if you take the antidote of warfarin, the antidote is your vitamin K1. But why do we consider the fresh frozen plasma as a treatment of choice? Why? Because the onset of action of fresh frozen plasma is immediate, whereas if you take the action of vitamin K1, the action will be delayed. Okay, so if you see the treatment of this particular warfarin, the treatment is by fresh frozen plasma. What this fresh frozen plasma do? This will provide the clotting factors. Alright, this fresh frozen plasma will provide the clotting factors. And this fresh frozen plasma, it is considered as the treatment of choice. So, if you take the treatment of choice, it is your fresh frozen plasma. Now, why fresh frozen plasma is the treatment of choice? Because it will provide the clotting factors and the onset of action is immediate. But if you take the antidote of, right, if you take the antidote of the warfarin, it is vitamin K1. Right, it is your vitamin K1. So, vitamin K1 it is not considered as a treatment of choice. Why? Because the action is delayed. Right, because the action is delayed. Alright, next. Now, if you take the metabolism of this particular warfarin, this warfarin, remember, whenever it is given orally, it is absorbed well from the GIT. Right, it is absorbed well from the GIT, right. Once it is absorbed well from the GIT, it is bound to the plasma proteins. Right, once it is absorbed from the GIT, it is bound to the plasma proteins. Almost nearly around 99% of the warfarin is bound to the plasma proteins. Now, if you take the kinetics, right, if you take the kinetics part, remember the pharmacokinetics, it changes from first order kinetics to the zero order kinetics. Right, it changes from the first order to the zero order kinetics, right, within the therapeutic concentration. The other point is this warfarin, it will cross the placenta. Right, this warfarin, it will cross the placenta during pregnancy. So once it crosses the placenta during the pregnancy, it will cause what is called as the fetal warfarin syndrome in the newborn, right. So the teratogenicity caused by warfarin is fetal warfarin syndrome, right, fetal warfarin syndrome. Now, this fetal warfarin syndrome, it is also called as the contradi syndrome, right, this is also called as the contradi syndrome. Now, what will be the manifestations of this fetal Warfarin syndrome? Remember, the manifestations of this particular, the contractile syndrome is number 1, right, number 1, growth retardation, number 2, stippled epiphysis, right, number 2, what we have is stippled epiphysis, and later they can also have hypoplasia of nose and the hand bones, right, hypoplasia of nose and the hand bones. Okay, so these are the manifestations what you come across in the contractile syndrome or the fetal Warfarin syndrome. Alright, that is the reason why in pregnancy the Warfarin is contraindicated. Right, that is the reason why in pregnancy the Warfarin, it is contraindicated. Alright, now however, it is not secreted in the breast milk, and that is the reason why it can be safely given in the nursing mothers. So another point is, it is not secreted in the breast milk. Now because it is not secreted in the breast milk, it can be given safely in right, it can be given safely in the nursing mothers. Alright, next. Now how will you adjust the dose of the Warfarin? Right, what are the parameters what you look for adjusting the dose of the Warfarin? So before that, let me shortly revise what we have discussed until now. If you take the adverse effects of the Warfarin, it is the bleeding is the most common adverse effect. And if the patient develops bleeding due to overdose of Warfarin, the fresh frozen plasma is the treatment of choice, but the specific antidote is vitamin K, but the action will be delayed. And if you take Warfarin, it is absorbed well from the GIT and it is highly plasma protein bound. 99% of it is plasma protein bound. And if you take the kinetics, its kinetics, they change from the first order to zero order within the therapeutic concentration. And the other point is, it crosses the placenta and it can cause the fetal Warfarin syndrome, and that is also called as the contractile syndrome. And what are the manifestations in fetal Warfarin syndrome? That includes growth retardation, stippled epiphysis, hypoplasia of nose and hand bones. That is the reason why in pregnancy it is contraindicated. However, it is not secreted in the breast milk and it can be safely given to the nursing mother. Now let me tell you, how do you assess the Warfarin overdose and how do you adjust the dose of the Warfarin? So to adjust the dose of Warfarin, remember, prothrombin time is used. Right, to adjust the dose of Warfarin, prothrombin time is used to adjust the dose of Warfarin. Why? Because it mainly affects the extrinsic pathway. This point is a very important multiple choice question. Warfarin, it mainly affects the extrinsic pathway. Because it mainly affects the extrinsic pathway, we have to look for the prothrombin time to adjust the dose of Warfarin. Now, the better test for monitoring the effect of the oral anticoagulant is the INR. Right? The better test for monitoring the effect of the oral anticoagulants. Right? The better test for monitoring the effect of oral anticoagulants is international, INR stands for International Normalized Ratio. Now, this INR, International Normalized Ratio, has been developed by WHO and it is based on human brain thromboplastin. Right? So it is developed by WHO and it is based on, right, it is based on human brain thromboplastin. Right, it is based on human brain thromboplastin. Okay. Now how do we calculate this INR? The INR, it is equivalent to prothrombin time of the patient, right, prothrombin time of the patient, it is divided by prothrombin time of reference, right, it is divided by the prothrombin time of reference and of, right, of the ISI. Now what does this ISI stands for? It is International Sensitivity Index, right, this particular ISI, it stands for International Sensitivity Index. Alright, next. Now this International Sensitivity Index, it depends upon the sensitivity of reference thromboplastin to WHO standard thromboplastin. Remember this International Sensitivity Index, it depends on the sensitivity of reference thromboplastin to WHO standard thromboplastin. Next. Now for example, if the individual has developed the overdose and the individual had the bleeding, now how will you manage the patient? The point is, so you have to completely monitor the INR. If the INR of the patient, if it is less than 5, then what you need to do is INR less than 5 but definitely above the therapeutic range. What is the normal INR? Normal INR is 1 to 1.5 is the normal INR. Whereas whenever you are giving warfarin, you have to maintain an INR of 2 to 3. Right, whenever you are giving warfarin, you need to maintain the INR of 2 to 3. So if the INR is less than 5, it is definitely above the therapeutic range. So what you need to do is, don't give any treatment, you just discontinue warfarin. Right, you just discontinue warfarin temporarily and then you need to start low dose. Right, then you need to start low dose. Okay. Now, but if INR, if it is in between 5 to 9, right, if INR is in between 5 to 9, then you have to give vitamin K1 of 1 milligram. Right, vitamin K1 of 1 milligram has to be given. And if INR is more than 9, then in such clinical scenario, right, INR is more than 9 but there is no bleeding, right, but there is no bleeding. So you have to give same vitamin K1 of 2 to 3 milligrams, of 2 to 3 milligrams. And if INR is more than 20, right, if INR is more than 20, in such case you have to give fresh frozen plasma. Right, in such case you have to give fresh frozen plasma. Alright, next. And this particular drug warfarin, it shows number of drug interactions. Therefore, the warfarin, it requires dose adjustment with several medications. I will tell you all those. Alright, so before that, remember the dose of the warfarin, it is monitored by your prothrombin time. Next, the point what you should remember is, the better test for monitoring the effect of oral anticoagulants is INR, and it has been developed by WHO and it is based on the human brain thromboplastin. And this INR is equivalent to prothrombin time of the patient divided by prothrombin time of reference of the ISI, where the ISI is International Sensitivity Index that depends on the sensitivity of reference thromboplastin to WHO standard thromboplastin. And if you take the management of warfarin overdose, If INR is less than 5, that is above the therapeutic range, you need to discontinue warfarin temporarily and then start at the low dose. And if the INR is in between 5 to 9, you need to give vitamin K of 1 milligram. And if it is more than 9 but there is no bleeding, you need to give vitamin K1 of 2 to 3 milligrams. And if it is more than 20 and if there is bleeding, right, either more than 20 or there is bleeding, then immediately you have to give fresh frozen plasma. Now let me tell you that there are certain drugs which will be having interaction with the warfarin. That is, some drugs, they will increase, right, some drugs, they will increase the effect of warfarin. Whereas on other hand, there are certain group of drugs, they will decrease the effect of warfarin. Right, some drugs, they will increase the effect of warfarin, and some drugs, they will decrease the effect of the warfarin. Now, drugs increasing the effect of warfarin, right, drugs increasing the effect of warfarin, in such clinical scenario, you need to require the dose reduction. Okay, so dose reduction of warfarin is required. Whereas some of the drugs, they will decrease the effect of warfarin, right, and in that clinical scenario you require, right, you require increase in the dose of, right, increase in the dose of the warfarin. Now let me tell you what are the drugs which will increase the effect of warfarin. These drugs which will increase the effect of warfarin, they include, number 1, broad spectrum antibiotics, right, broad spectrum antibiotics. Next to this particular broad spectrum antibiotics, we have cephalosporins like cefamandole, right, cephalosporins like cefamandole, and the another cephalosporins like cefaperazone, right, cefaperazone, and we have another drug which is called as the moxalactam, right, another drug that is called as moxalactam. So these are some of the cephalosporins, and the other drug that is moxalactam. And apart from this, the other drugs which will increase the efficacy of warfarin and where you require the dose reduction is whenever the individual is taking aspirin, and other important drug like phenylbutazone, right, another important drug that is phenylbutazone, and various microsomal enzyme inhibitors like erythromycin, right, erythromycin, and as well as your cimetidine, right, erythromycin and as well as cimetidine. So remember, drugs increasing the effect of warfarin, thus requiring dose reduction of warfarin, is all these particular group of drugs. On other hand, you take enzyme inducers, right? What are enzyme inducers? The enzyme inducers, they include the drugs that is rifampicin, right, drugs like rifampicin, and as well as the griseofulvin, right, as well as the griseofulvin, and the oral contraceptives, right, the oral contraceptives, right, what they will do, they will increase the clotting factors, right, they will increase the clotting factors. So on the other hand, enzyme inducers like rifampicin, griseofulvin and oral contraceptives, they decrease the efficacy of warfarin. So they will require, whenever you are giving these drugs, you need to increase the dose of warfarin. So these are the drug interactions associated with the warfarin.